Hello, and a very good afternoon to all our viewers to this new session of Dent-E-ssentials. Today, we will be talking about unlocking the secrets, exploring access opening in root canal treatment. The importance of gaining straight line access is indisputable. Poor access cavity design could lead to inadequate cleaning, shaping, and obturation, compromising successful outcomes of a root canal treatment. Therefore, sound knowledge of the internal and external anatomy of the teeth is necessary for successful access cavity preparation. To discuss more about the concept of precise access, we have with us today Dr. Kanchan Shetty from Sharjah. Dr. Kanchan's passion for endodontics began during her dentist school training, where she was drawn to the challenging and intricate nature of root canal procedures. After completing her graduate degree, she pursued her master's in endodontics and has since become a skilled practitioner in the field. In addition to her technical skills, Dr. Kanchan is also known for her warm and friendly demeanor, making her patients feel at ease throughout her treatment. She takes the time to listen to her patients' concerns and thoroughly explains each step of the procedure, ensuring that they are fully informed and comfortable with the treatment plan. Dr. Kanchan is committed to ongoing learning and stays up to date on the latest advancements in endodontics. A dedication to providing the highest quality of care and patient satisfaction is evident in the many positive reviews that she has received from her patients over her 7 years of practice. It's an absolute honor to have you with us today, Dr. Kanchan. You may please share your screen and begin your presentation. Over to you.
Good afternoon, everyone. I'm Dr. Kanchan Shetty. I've completed my graduation from MGV Nasik and my post-graduation from SDM Dharwad. I'm currently practicing in UAE. The topic for today's seminar is Unlocking the Secrets, Exploring Access Opening and Root Canal Treatment. Endodontics plays a very important role in preserving the health and the function of the teeth afflicted by pulp and periapical diseases. Central to achieving success in endodontic treatment is the precise and skillful creation of access opening, which provides a crucial entry point for the subsequent cleaning, shaping, filling procedure. We will be covering the following topics in today's seminar. Coming to the introduction, endodontic cavity preparation deals with both coronal and radicular portion that flows together into a single preparation. Access is the first and the most important phase of non-surgical root canal treatment. Without adequate access, instruments and materials become difficult to handle properly in the highly complex and variable root canal system. Coming to the introduction of the morphology of the tooth, we have the pulp chamber, which consists of the roof and the floor. The roof is a dentine covering the pulp chamber. The floor is parallel to the roof, present below the chamber, and form the dentine of the furcation area. The pulp horn are accentuation of the roof of the chamber directly under the cusp, whereas the orifices are the openings in the floor of the chamber leading to the root canal. Apical foramen is the exit of the canal. Coming to the objectives of the access cavity preparation, one is to remove all the carious portion. 2 is to conserve the sound tooth structure. 3 to completely de-roof the pulp chamber. 4 to remove all the coronal pulp tissue which is vital or necrotic. 5 is to locate all the root canal orifices. 6 is to achieve a straight line or direct access to the apical foramen or the initial curvature of the canal. 7 is to establish restorative margins to minimize marginal leakage of the restored tooth. Coming to the definition, it is the opening prepared in the tooth to gain entrance into the root canal system for the purpose of cleaning, shaping, and obturation. Coming to the principles of endodontic cavity preparation, we'll go in detail of each one of these steps. The outline form. The outline form mainly is divided into 3 parts, as the size, the shape, and the number and position of the root canals. It is said that the external outline evolves from the internal anatomy. The preparation from inside to outside, that is the mechanically projecting internal anatomy of the pulp onto the external surface. Coming to the size, in young patients, these preparations are more extensive than in older, in whom the pulp has receded and the chamber is small in all the 3 dimensions. The shape. The finished outline form should accurately reflect the shape of the pulp chamber. For example, the floor of the pulp chamber in molar is usually triangular shape, owing to the triangular position of the orifices of the canal. This triangular shape is extended onto the walls of the cavity, out on the occlusal surface. Hence, the final occlusal cavity outline form is generally triangular shape. Also, it depends on the number of root canals. the curvature in the canals, and the position of the canals. Next, coming to the convenience form. This makes the preparation and the filling of the root canal more convenient and accurate, which has four benefits. That is, the unobstructed access to the canal orifice, direct access to the apical foramen, cavity expansion to accommodate filling techniques, and the authority over the instrument. Failure to extend the convenience form in the access cavity outline form will cause root perforation, ledging, instrument breakage, zipping, or apical transportation. I personally believe once you look at the axis from the top, if it's a molar, if you look, you should see all the canals. But there are recent advances which says that it should be as minimal as possible. But that again depends on the microscope that you're using, or the loops, or the magnification, the type of magnification that you're using. If you're not using these magnification and you're trying to do a conservative access opening, you will eventually might lead to missing of canals, mainly the MB2 canals, or there will be breakage of the instrument at the orifice, or there will be a ledge formation seen. If you're not using magnification, try to make your access not very invasive, but at least you can see from top all the canals should be visible to you. You can also give a little beveling only on the occlusal surface without disrupting no tooth structure. Next, coming to the third principle, that is removal of caries dentine. Coming to the third principle is removing of the remaining caries dentine and defective restoration. The first is to eliminate mechanically as many bacteria as possible from the interior of the tooth. Second is to eliminate the discolored tooth structure that would ultimately lead to staining of the crown. Third is to eliminate the possibility of any bacteria-laden saliva leaking into the prepared cavity. You can remember that if there is not enough tooth structure above the gingiva to place a rubber dam and seal against the saliva, a simple gingivoplasty can be established to increase the crown length. Also, you can use a silicone clamp in such cases. Coming to the toilet of the cavity, all the caries, debris, necrotic material that may obstruct the canal enlargement must be removed before radicular preparation. Soft debris should be removed from the chamber. Coronal debris that may stain the crown later, particularly in anterior cases, should be removed. Round burrs and endodontic spoon excavators are used along with hypochlorite to remove such stains and caries. Next, coming to the need for ideal access cavity. One, there is a proper debridement of the entire canal system, reduces the risk of fine breakage, allows proper irrigation from the top till the bottom of the canal, leads to proper screening and shaping of the canal, and proper and condensed obturation can be done. Coming to the guidelines, visualization of proper internal anatomy, evaluation of the CEJ as it plays a very important role, and the occlusal anatomies, preparation of the access cavity through the lingual and the occlusal surface, removal of all defective restoration caries before the entry into the pulp chamber, removal of the unsupported tooth structure, creating an access cavity wall which has a straight line access, delay in dental dam placement until difficult canals have been located, and then you can place the canals, the clamp, location, flaring, exploration of all the root canal orifices, inspection of the pulp chamber, and tapering of the cavity walls. Next, coming to the guidelines, one by one, visualization of the internal anatomy. The diagnostic and radiographs can be taken. Position to find the position of the pulp chamber, if there is calcification or not, to see the number of roots and the curvature present, and also to have an approximate idea about the length of the canal. Coming to what is a fast break appearance, a lot of time you will see on the x-rays, you can see the canal, and suddenly there is a disappearance of the canal, and then you see the canal at the end. Whenever there is a disappearance or sudden break in the canal, there is always an indication of bifurcation of the canal taking place, which is known as a fast break appearance. Also, palpate the attached gingiva to check for the root curvature and the tip of the root. Coming to the guidelines, evaluation of the CEJ and occlusal anatomy, its complete dependence on the occlusal anatomy can lead to procedural errors. Kastner and Ranker quoted that CEJ is an important landmark for locating the pulp chamber and the orifices. Preparation of the access cavity through the lingual and the occlusal surface. In anterior cases, is done lingually, and in the posterior cases, done occlusally. For achieving a straight line access, they diminish the aesthetic and the restorative concerns. Also, mandibular incisors, you can do it incisor access opening can be done. Some authors have recommended that the traditional anterior access for the mandibular incisors may be moved into lingual surface to the incisal surface in selected cases. This allows better access to the lingual canal and improves the canal debridement. Coming to the removal of the defective restoration and caries. All the defective restoration and caries must be removed before entering the root canal system. The caries dentine must be removed as it prevents irrigating solution from leaking from the rubber dam onto the mouth. On excavation, the tooth structure is not sufficient for the placement of rubber dam, then the crown blending procedure should be carried out. I always believe in relieving the tooth structure of tooth from the occlusal. Before I start my access opening, I always make sure I do occlusal reduction, which is the first step, because the root canal treated teeth are more prone to fracture because there is an increased brittleness due to loss of water and collagen cross-linking, loss of tooth structure due to caries and access cavity, loss of proprioceptive mechanism as the tooth becomes dead, relieve the pulp PDL, the periodontal ligament, and the periapical tissue from the masticatory forces. Also, because there is a loss in the marginal ridge, there is a loss of strength. In MOD cavities, there is 60% loss of tooth strength, whereas in endodontic teeth are subjected to greater load compared to a normal vital teeth. Next, removal of the unsupported tooth structure. After the access cavity, the tooth resistant to stress is reduced. All the unsupported tooth structure must be removed. The access cavity wall that do not restrict straight line access to the apical foramen will lead to hindrance in the use of instruments. We should make sure that the instrument should be placed easily without any interference till the apical of the root. If the canal is severely curved or leaves the chamber floor at an obtuse angle, sufficient tooth structure must be removed for a straight line access. After the access cavity is prepared, the tooth resistance to stress is reduced. Thus, all the unsupported tooth structure must be removed to prevent tooth fracture and to have a proper accessibility of the restoration. Failure to follow so can lead to root perforation, ledge formation, instrument separation, or apical transportation. One can delay the rubber dam placement until the difficult canals have been located and confirmed. I personally believe to place the rubber dam in the first step only, but this is a traditional way of doing it. In crowded teeth, in rotated teeth, in fractured to the till the gum line, or heavily restored or calcified cases, you can do the initial access opening and then go for a rubber dam placement. Micro openers are flexible stainless steel instruments which are of 4% and 6% taper that can be used to check for the orifices. Also, dental dam must be placed when the chambers are penetrated and the walls are identified. Coming to location, flaring, exploration of all the root canal orifices. A sharp endodontic explorer is used to locate the orifice and determine their angle of departure from the pulp chamber. The coronal portion of the canal is flared. A small pre-curved K-file can be used. Lubricants like RC prep may be used. Inspecting the pulp chamber, surgical loops, operating microscopes are useful for which increases the visibility, particularly in constructed and calcified or the curved cases. Tapering of the cavity wall. Proper access must be gained, and the tapering of the walls is at widest at the occlusal surface. Again, this is a very traditional one. The modern technique tells you to be more conservative and keep it tapering at the widest at the orifice and keep it convergent like this. Next, coming to the armamentarium, a magnification is a must. I think one of the best investment in dentistry is magnification. One must go for magnification. I personally use loupes. If you can afford for a microscope, then just go for it. But loupes are of great asset for root canal treatments. It makes a vast difference while treating. Like before, when I used to do without the loupes, now I just can't work without loupes. So loupes are a must. Please invest for a good quality loupes. Don't damage your eyes by using the cheap ones that are available in market. So loupes are a must, magnification, and the loupes without light is of no use. So illumination plays a very, very important role in magnification. Handpiece, bores. I've seen a lot of people using round burrs, like carbide burrs, diamond burrs, such burrs, for orifice opening, or blades laden for orifice opening. Endodontic Explorer D16 is very good. It is very sharp one. Also, try using D16 from a good brand, or JW70. Endodontic spoon excavators and ultrasonic tips. I personally use these two burrs, without which I'm just handicapped without these burrs. Endodontic Endo Access burr is by Dentsply. It comes in various number 1, 2, 3. For anteriors, I will use a smaller number. For posteriors, I go for a bigger number. Once I gain my access through endo access burr, once I get a drop in the pulp chamber, then I go to endo Z burr. And cause endo Z burr doesn't have a cutting tip, so it just has cutting. The shaft has the cutting blades, so you're not going to perforate or ledge the access. It's only to remove the walls of the chamber. So these are my go-to burrs for endodontic treatment. Next, coming to the pulp chamber laws, Kastner and Ronkow gave few laws which hold very, very true in almost all the cases. Law of centrality. This law says that the floor of the chamber is always located in the center of the tooth at the level of CEJ. Law of concentricity. The walls of the pulp chamber are always concentric to the external surface of the tooth at the level of CEJ. You can see in the diagram, the first diagram says that it is always at the center. The second diagram says it's like a concentric circle, like the amount of, at the CEJ level, it is concentric with the external surface. The law of CEJ says that the distance from the external surface to the clinical crown of the wall of the pulp chamber is same throughout the circumference of the tooth at the level of CEJ, making the CEJ the most consistent landmark for locating the position of the pulp chamber. Now, if you see the distance from the external wall and the internal wall, it is all throughout the circumference, the distance is the same. And CEJ plays a very important role, as all these laws hold true in almost all the cases. Now coming to the laws of symmetry. The first law of symmetry says that except for the first molar, except for the maxillary molars, the canal orifices are equidistant from a line drawn in the mesial-distal direction of the pulp chamber. So if you take a tooth and if it's the mesial and the distal surface, if you draw a line, the canals are always located from this line. They are equidistant from this line. The second law of symmetry states that except for maxillary molars, if this is a tooth, if you draw a mesial-distal line and you draw a perpendicular line to this mesial-distal line, the orifice will always lie on this line perpendicular to the mesial-distal line. You can see in the diagram below, if you draw a mesial-distal line and then you draw a perpendicular line, this is your mesial-distal line. And when you draw a perpendicular line over it, it is always on the perpendicular line. The second law is the law of the color change. The pulp chamber is always darker in color than the walls. This is which is also known as a dentinal map, which is of great help in locating the canals. Next, coming to the laws for the orifice location. 1. The orifices of the root canals are always located at the junction of the wall and the floor of the pulp chamber. Second, the orifices are always located at an angle to the floor and the wall junction. Third, the orifices of the root canals are always located at the terminus of the root development of the fusion lines. Coming to canal configuration, every tooth has a different canal configuration. This configuration is classified by vertices. Here we can see 1-1 configuration, that is one canal which ends into one canal. 2-1 configuration, two canals which join at the end as one canal. 1-1 configuration, one canal which bifurcates into two canals but finally ends into one canal. Coming to 2-2 configuration, two canals which end at two separate canals. 1-2 configuration, one canal which starts as one canal but in the middle part it gets bifurcated into two separate canals. 3 is two canal merging into one canal and then separating into two separate canals. The 7th classification is one canal bifurcating into two, merging as one, and again bifurcating into two separate canals. And the eighth one is 3 canals going as 3 separate canals and ending with 3 separate exits. Next, coming to the pulp anatomy of each and every tooth, starting with the maxillary central incisor. It has 3 pulp horns. The distal view shows a presence of a lingual shoulder. If you see from the distal aspect, maxillary central incisor is a single rooted tooth with more broad labiolingual aspect. The access cavity of the maxillary central incisor is triangular in young teeth, with the base towards the incisal aspect, whereas it is ovoid in case of older teeth when you see it mesodistally. Next, always when you're gaining access for maxillary central incisor, take your endoaccess board and start with the center of the lingual aspect. First, you go perpendicular. If this is the tooth, you go perpendicular, and then you take your bore parallel, and then you go parallel to the wall of the labial wall. Make sure there is no lingual shoulder present. The initial preparation is made with exact center on the lingual surface at the position marked as X with a round burr. A tapered fissure burr is then taken at a right angle to the long axis of the tooth. Only the enamel is penetrated. Maintain the point of burr in the central cavity and rotate the handpiece towards the incisal so that the parallel long axis burr of the tooth. Preliminary cavity outline is funnel shape and then planned incisally with a fissure burr. Enamel has a short bevel towards the incisal and a nest is prepared in the dentine to receive a round burr. Then number 2 or number 4 round burr is used along the long axis of the tooth. Walking from inside the chamber to outside, the round burr is used to remove the lingual and the labial walls of the pulp chamber. Also, if there is any lingual shoulder present, it is removed, giving a continuous, smooth flowing preparation, and often a long tapering diamond point burr is better to remove the lingual shoulder. The round burr is used incisally and laterally to eliminate any pulp horn debris and bacteria present. The final preparation is with preparation with the reamer in place. The instrument sharps clears the incisal cavity margin and reduce lingual shoulder, allowing the unstrained approach or the apical third of the canal. I usually use the endoaccess board first. I hit it at the center, make an axis, and then I go with the endo Z board, and then I make a triangular shape access cavity. Next, coming to the lateral incisor, the roots are conical in shape and has an apical distal curvature. The root canal is usually 1, but 2 or 3 canals have also been reported. Lateral canals are frequently seen as much as 26% of the cases. The access opening is very similar to the central, but there's slender triangle if the pulp horn is more prominent and more ovoid. The access opening is similar to the central, but it is slender and triangular if the pulp horns are more prominent and ovoid if they are not prominent. The average length of the canals are from the tip of the incisal is around 20 to 23 mm. The pulp chamber is similar to that of the central and has 2 or no pulp horns. The shape of the pulp chamber may be round, oval, triangular. Lingual shoulder is present, should be removed. Pulp is wider mesodistally in younger teeth than in adult. Next, when you go for maxillary canine, the pulp chamber is the largest among the single-rooted teeth. It is triangular labiolingually and flame-shaped mesodistally. No pulp horn is present. The distal view would show the presence of lingual shoulder just below the cervical region. The canal is straight in 39% of the cases. The access outline is oval or slot-shaped due to the absence of pulp horn. Next, coming to the mandibular teeth, the pulp chamber are the smallest in the arch. The pulp chambers are flat mesodistally and ovoid labiolingually. It has 3 pulp horns. The root and the root canal are flat mesodistally and wide labiolingually. The root shows a ribbon-shaped configuration in middle 1/3, whereas a bifurcation usually occurs, and perforation can occur in these cases. Also, always remember the mandibular central and lateral incisors usually show 1 canal, but there are the instances or the prevalence of 2 canals is more in such cases. Usually, the missed canal is the lingual canal. The one that we get immediately after access opening is usually the buccal canal. If you move little bit more lingually, you might find two canals in mandibular lower incisors. The access opening is large, triangular funnel shaped in the young tooth, whereas ovoid in cases of adult teeth. You can see in one of the diagrams, you can see two canals present. Coming to mandibular canine, the pulp chamber is more wide labiolingually, and the access opening is ovoid of funnel shaped preparation. Coming to maxillary first premolar, the pulp chamber is narrow, mesodistally, and wide buccolingually, one pulp horn under each cusp. The roof of the pulp chamber is coronal to the cervical line. The floor of the pulp chamber is usually convex. It usually has toe roots. When roots are fused, the groove line in the occluso-apical direction divides the root into the buccal and the palatal portion. If you get the canals, if the canal is placed way buccally, that means there will be a lingual canal. If the canal is placed exactly at the center, then the chances of two canals are less. But if the canal is placed way buccally or way lingually, that means definitely there has to be one more canal. Pulp anatomy of the maxillary premolar. The pulp chamber is similar to first premolar and has a single orifice but two pulp horn. The root canal is single rooted but may have two or three canals. The mesial view is recently calcified. Is calcified, single root with large canal. In adult, there is a high bifurcation of the separate canals, and the canals are usually ovoid buccolingually. There is also presence of three roots in the three canals in the premolar. It is also known as molarized premolar. It looks similar to the premolar. It looks similar to the molar tooth with three canals, or there is high chances of three roots present in premolars. Once you gain the access from the occlusal surface, you get the drop. Then you take your endo-Z bore and you move buccally or lingually to see if there are two canals or one canal. But during this process, try not to be more invasive or disrupt more tooth structure. Coming to the anatomy of the mandibular first premolar, the pulp chamber is narrow, prominent buccal horn and buccal cusp can be seen, and a small lingual cusp with a 30-degree lingual tilt is seen. The root and the root canal usually the other root with a single canal, which is cone-shaped or a simple outline. The mandibular first premolar is a transition from the anterior to the posterior, and anatomic structure resembles both. It is narrow mesodistally and prominent buccal horn is seen. The buccal cusp is more prominent compared to the lingual, which is smaller, which is with a lingual tilt of 30 degree. The root is narrow and broad mesodistally. The root is narrow mesodistally and broad buccolingually. The mesial view shows a single-rooted or a bifurcated canal with a single apical foramen. Access opening is ovoid or funnel shaped. To compensate a 30-degree lingual tilt to prevent perforation in the enamel, we penetrate in the upper third of the lingual with an incline to the facial cusp. When you're using the bond, make sure you have an incline so that you don't perforate the lingual aspect. Coming to the mandibular second molar, their lingual horn is more prominent. They are usually single root. The buccal view shows an apical distal curvature of 40% in 40% of the cases, whereas the mesial view shows a broad buccolingual ribbon-shaped pulp. Access opening is ovoid shape and is wider mesodistally. Also, mandibular premolars are very unpredictable. They are also known as the enigma to the endodontist because they have a very different variation, especially in the roots. There is usually you will see a single rooted and then there's a bifurcation. You will see a single rooted and then there is trifurcation. There is a lot of variation that is seen in mandibular premolars, and they're one of the most difficult and unpredictable teeth along with the third molars. But the canal configuration varies a lot. One of the most difficult cases that I have treated till now has to be hands down the mandibular premolars because of the canal formation, configuration and all. A lot of times you see bifurcation, trifurcation, which are just not easy to negotiate. In such cases, you either loops makes a big difference, or most of these cases can be dealt very easily under a microscope while doing a root canal treatment. Again, you see a case over here where there is a single canal which goes and bifurcates into two. You gain the access from the center, from the occlusal surface, and then you move buccally and lingually to find if there is another canal, or if the axis is center, if the canal is in the center, then there won't be another axis, another opening. Try to use radiographs at different angulation, especially with a mesial or distal tilt. Makes a huge difference in such cases. Coming to the maxillary first molar, the pulp chamber is the largest in the dental arch. The pulp horns, there are 4 pulp horns. The pulp roof is rhomboidal in shape. The floor is triangular in shape with the apex in the palatal orifice. The anatomic dark lines called dentinal maps connects these orifices. The dentinal maps plays a very important role. The dentinal map looks darker than the other part of the chamber. And the dentinal maps help in locating the orifices very well. So the maxillary first molar usually has the mesiobuccal root beneath the mesiobuccal cusp. The distobuccal root, that is, it is somewhere in between behind the distal cusp. So the maxillary first molar has mainly 3 canals: the mesiobuccal canal, the distobuccal canal, and the palatal canal. But the chances of mesiobuccal 2, MB2, is as high as more than 90% of the cases. Only if you start searching for an MB2 canal, you will get an MB2 canal. It is not very easy to find, but it is also it is one of the highest. The failure in maxillary molar is because of failure to negotiate an MB2 canal. There are 4 canals that are seen, but usually MB2 is calcified. But MB canal, the mesiobuccal canal, have a distal curve and it may also not maybe straight or S-shaped. Also, a lot of time the mesiobuccal canal is at an angle or it is curved. So the entry of mesiobuccal canal is from the distobuccal side, so that the access is gained a little much easy compared to if you directly put the file from the mesiobuccal cusp. Try to put the file from the distobuccal canal. The angle should be like this. Coming to NB2, a lot of studies have been done which says that there is a prevalence of 90% of cases have MB2. The distance between the MB1 and MB2 is somewhere around 2.3 millimeter apart. Also, few studies have stated it's around 1.82 millimeter apart. MB2 orifice can sometimes be found close to even palatal orifice. While the 2 mesiobuccal cusp orifice are most common, the 3 can also be present. The anatomical studies have reported MB2 as mesial present in the mesial root, and then second molar to be present around 69 to 93%. The complex root anatomy of maxillary molars lies behind the high rate of endodontic failure. A lot of failures are seen in maxillary molars due to not negotiated or missed MB2 canals. You can use an ultrasonic tip, you can use a normal scaler tip to search for the MB2 canals. It is high in cases of young patients. As you go for older patients, the chances of MB2 is less, but it's still present. It's still present in a lot of old patients also, but in pedo patients, in younger teenage patients, there is a high prevalence of MB2 canal. So the MB2 canal is always placed just behind, lingual to the MB1 canal, in between MB1 and the palatal canal, but more towards the MB canal. Coming to a shamrock preparation, which is says by Lubeck, says that when you're finding the MB2 canal, don't go more in the search of MB2 canal and destructing the tooth structure. Rather go like this flower shape appearance. Just extend your cavity towards the MB2. He said that the entire wall need not be extended in the event that instrument's impingement occurs owing to the severely curved roots or the extra canal. In extending, only that portion of the wall needed to be free of the instrument, which gives a clover leaf appearance and may evolve as an outline form. So it states that to find an MB2, don't go in an extent to destruct most tooth structure. Just extend your cavity in the area of the MB2 rather than the whole wall of the mesial wall. Coming to maxillary second molar, the pulp chamber is similar to that of the first molar, but it is more narrow and mesorostally. The roof is more rhomboidal in shape. MB and DB canal orifices are very close to each other and may appear to have a common opening. The buccal view may show 3 roots with 1 canal each, but in an adult tooth, anomalous appearance of one root with two canals is also seen. Usually it is three canals, the MB, the DB, and the parietal. But a lot of time you will also see in the sevens, the buccal and the lingual canal, which are merging into one, or they are two separate canals. You will just see the dentinal map as a straight line. Next, the outline form is triangular in young and ovoid in adult patient. There are three roots which are closely grouped to each other and may be fused to form a single conical in 46% of the cases. Next, coming to maxillary third molar, indication of RCT. Before, a lot of foreign countries don't prefer doing third molar root canal. They prefer extracting it. In India, when I used to practice back then, I used to do a lot of third molar RCs. But the only thing is you can't place the crown. So make sure that if you're investing so much time, efforts in doing a third molar RCTs, it should be easily accessible to the dentist and to the patient, so that the patient can well maintain the teeth by brushing in that area and preventing food lodgement and secondary decay in such cases. So if it is indicated for root canal, the radicular anatomy and the canal morphology is unpredictable. It is highly unpredictable in the molars, upper and lower. It may have a variation from 1 to 4 roots, 1 to 6 canals, or a C-shaped canal. Usually maxillary third molars are 3 rooteds and 3 canals. The axis could be oval, widest buccolingually, or it could be rounded or an obtuse triangle. Indications for root canal for third molar could be loss of first and second molar, function tooth with adequate space for hygiene and full eruption, strategic abutment when the first and second molar are lost. You will see either the mesobuccal, distobuccal, and parietal lie almost as a straight line, very close to each other. Next, coming to mandibular first molar, it is the average length is somewhere around 21 mm. The pulp chamber, there are 4 horns: mesiobuccal, mesiolingual, distobuccal, distolingual. The roof of the pulp chamber is often rectangular in shape. The floor is rhomboidal in shape. There are 3 orifices: mesial, mesiolingual, mesiobuccal, mesiolingual, and distal. The MB is beneath the mesiobuccal cusp. The mesiolingual is near the central groove. A depression formed between the mesial and the lingual walls. The distal is the widest buccolingually and oval in shape. So usually you will find 3 canals, that is MB, ML, and distal, which will form a triangle. Mesiobuccal will be right beneath the mesiobuccal cusp. Mesiolingual will be at the center, whereas the distal will be a big canal. But if you find a distal canal more buccally or more lingually, that means there is another canal. Always search for 2 distal canals because the chances of 2 distal are more. If there is one distal which is in the center and which is big, then the chances of 2 distals are less. So once you gain access, you start from the mesial aspect. The cavity is shifted more mesially, the pulp chamber. So you go mesially first. Once you find the mesiobuccal canal, you find a drop. Use the endo-Z board to make the shape of the cavity and start searching for distobuccal or distolingual. It will be either a rhomboidal shape or a triangular shape axis. Mandibular second molar, it's same as the first molar, but it is more smaller. Also, the root canal orifices are much smaller and closer. Also, with first molar, the chances of mid-mesials are more nowadays. But with really high illumination magnification, only you can see mid-mesial canal. The mid-mesial is placed between the mesiobuccal and the mesiolingual. In middle of these two, you will find mid-mesial canals. In case of first molar, mandibular first molar. Coming to mandibular second molar, again, you will find either 3 or 4 canals. You will also find C-shaped canals more predominant in mandibular second molar. Coming to mandibular third molar, they are again very unpredictable. The roots can be fused, short, severely curved, malformed. They may have 1 to 4 roots. C-shaped canals are again possible. The root surface volume in contact with the bone. The prognosis also depends on this aspect. When there are 3 or more canals, it could be rounded or rhomboidal in shape. If 2 canals, it will be rectangular in shape. If it can be successfully treated, but the prognosis also depends upon the various aspects. So make sure, again, if you're treating a third molar, it is easily accessible and easy for the patient to maintain, clean that area. Next, coming to C-shaped canal, it is mainly seen in second molars, mandibular second molars. There are different types. Like you can see, one is uninterrupted C. In this diagram, you can see there's uninterrupted C-shaped. Second is like a semicolon. Third is like a 3 separate canals. Fourth is like a single canal. And the last one, you will not see a canal lumen. You will just see a big, huge canal inside it. So the main cause of C-shaped roots or the canal is a failure of the Hertwig epithelial root sheet to fuse on either the buccal or the lingual root surfaces. Excuse me. The C-shaped root canal system was first reported in 1979, and most C-shaped canals occur in mandibular second molar, but they are also often reported in mandibular first molar and few cases of maxillary teeth. Coming to anomalies, different variation, that is radix entomolaris and radix paramolaris. Radix entomolaris is present as an additional distal lingual root in mandibular molars, an extra root on the lingual side. Radix paramolaris is presence of additional distobuccal root in the mandibular molars, the extra root on the buccal side. Coming to identifying the root canal, one must be very well aware about the anatomical variations and the number of canals present, the chamber, how the dental map looks like. Second, radiographs are of great help. Third, magnification and illumination helps in identifying the canal very fast and makes the work more easy. Ultrasonics are of great help in identifying MB2 canals, calcified canals, mid-mesial canals. Micro openers are instruments which help with taper, which help in opening the orifices. Dice can be used. Bubble test or the champagne test can be used, in which we fill the chamber with sodium hypochlorite. Wherever you see bubble, because of presence of pulp tissue, there is a canal in that area. The white line test is when you use, when the debris are settled down on the dental map, you see a white line, which indicates there is an orifice in that area. Red line test is with blood. When in vital teeth, you will see a red line which around the dental map, which helps in locating the orifice. Perioprobing can be used. Symmetry, laws of symmetry can be used. Law of color that we have discussed before can be used. These are the few ways that the Radon radar helped us in identifying the root canal. Next, there are some challenges when the tooth has little or no crown structure present. In such cases, you can go for gingivectomy, so that you get a proper hold of the grip for restoration. Creating an access opening or cavity on a tooth with little structure remaining may be simple, but chronic inflammatory process would be caused due to recession of the pulp or calcification. The loss of coronal anatomy and guide penetration angles makes access quite difficult. So before beginning, in such cases where there's a change in angle or something of that sort, you can use radiographs, and cervical crown anatomy must be studied very well. The depth of penetration needed to reach the pulp can be measured through radiograph. Next, if it is a highly restored teeth, the restorative material in the full crown rarely reproduce the original tooth anatomy in the exact position. So using direct microscope or transillumination of the cervical area can improve the visibility. Complete removal of large restoration before starting is the best option. Creating an access through an intact full veneer or a partial veneer should be done with proper caution. There may be changes in the root angulation or the tooth rotation. Also, in cases of repeat root canal, or if you're trying to gain access through the crown, make sure there is not a perforation of the crown or the root that is taking place. So be very conservative in such cases. For porcelain crowns and all, you can use a round burr with copious water spray. Once the porcelain is penetrated, use a transmetal carbide coated fissure burr to cut through the metal, and then follow the same guidelines. Teeth with calcified canal, because of chronic inflammatory process, causes narrowing of the canal. The canals are less calcified near the apex. Hence, every canal must be negotiated and cleaned and shaved. This is a very important point. It is always said that the canals are more calcified at the orifice than compared to the apex of the tooth. When the canal is located, a small K file can be used with a chelating agent and introduced. The file should not be removed until the canal is enlarged. I prefer using a C-pilot file in cases of calcified cases. I don't use a burr if I'm not getting a canal. I prefer using an ultrasonic tip to negotiate a canal. Coming to magnification, transformation, color changes, like said before, the chamber is more dark. That you can use dyes. You can use a champagne test by using sodium hypochlorite, or you can use by seeing the bleeding spot, that is a red line test. Crowded teeth, rotated teeth, one must be very careful in such cases because there is a change in angulation in the radiograph and also in the anatomy of the tooth. The conventional preparation may not be possible. An alternative approach can be taken depending on whatever is convenient and more aesthetically pleasing. Buccal preparation may be done, maybe treatment of choice in cases of buccal caries. Same way with the rotated teeth, the chances of perforations are more due to faulty angulations of the burr, which is with respect to the long axis. So one must be very careful while treating a rotated teeth. Other problems that are because of mistaken identification of already located canal. To prevent this, a file should be placed and the radiograph should be taken. Failure to locate an extra canal or a calcified canal, excessive gorging of the tooth structure, inadequate openings, failure to debride all the pulp tissue, furcation perforation caused by failure to measure the distance between the occlusal surface and the furcation. All the points discussed before, if dealt properly, and with proper knowledge about the canal anatomy and the root, one can prevent these things. Proper use of burr and proper magnification and illumination will help us to eliminate all these problems. And the best way to handle these problems is to prevent them from occurring at the first place with proper conservative approach. Also, tooth anomalies, certain anomalies render proper execution of endodontic treatment becomes difficult. So one must read in detail about these anomalies before starting such cases. Like cases like taurodontism will have a wider pulp chamber. All these cases should be dealt in with proper knowledge about the anomaly and then execute these discussed access opening points. Cases like dental dysplasia, taurodontism, dents in dente, or stenogenesis imperfecta, the pulp cavities are more small, obliterated. In hyperparathyroidism, may cause pulp calcification and loss of lamina dura. Hypofunction of the pituitary gland may lead to retarded eruption and open apices. Dental dysplasia is a hereditary condition where there is obliteration of the pulp chamber and the defective root formation. Taurodontism is characterized by short root and much larger than normal pulp chamber. Dents and dente is an invagination of the crown or the root on the lingual surface of the tooth. They have an enamel-lined space that communicates in the oral cavity, common in maxillary lateral incisor. Evaginatus is an extra cusp or a pulp horn. There is widening of the pulp chamber and the tooth is predisposed to decay. Dents in dente. I've seen cases of dents in dente with multiple root canals present. In such cases, it is similar to a C-shaped canal, and you should use the obturation technique that should be used in such cases should be warm vertical condensation, and copious irrigation of hypochlorite must be used. The other anomalies might be gemination, fusion, usually seen in mandibular lateral incisors. So one should know what is the difference between gemination and fusion. Accordingly, you will know number of canals present in that. Palatal developmental groove, which is seen in the cingulum of the incisor. Pulp stone is very common in mandibular molars. Bifurcation and trifurcation, as discussed before, is present in mandibular premolars. Presence of one root with one root canal is seen in maxillary second molar or mandibular second molar. Coming to errors in access cavity, labial perforation due to improper inclination of the burr or the tooth anomaly, failure to judge the inclination. One must make sure that if you are doing a central incisor, once you go straight, you don't go very deep inside and you perforate the labial wall. Rather, just go straight and then use another endo Z board to go parallel to the labial wall. Overextended preparation or an undermined enamel wall owing to failure to observe the pulp recession on the radiograph. One should not overextend or underextend their preparation. An underextended can later be overextended, but an overextended is already damage to the tooth structure. Failure to observe the distoaxial inclination in maxillary premolars and perforating the mesocervical aspect. Always make sure when you're doing a premolar maxillary, you are at the center and not more inclined mesially or distally, leading to perforation. Failure to expose a second canal, explore a second canal caused by inadequate incisor gingival extension of the access cavity. Like I said before, always in mandibular lowers, try to search for a lingual canal. While doing so, don't try not to perforate the canal, but a proper knowledge about which canal is placed on which side, which aspect of the tooth will give you a better ease in working or doing access opening. Coming to discoloration, usually you will see central incisors. There will be discoloration seen present because of trauma and all. Access cavities towards the incisal aspect. Try to cover the discolored area, remove the discoloration a little bit, how much of it is possible, but don't try to overextend it. Ledge formation is caused by loss of control of instrument passing through the access cavity prepared in the proximal restoration. Also, failure to locate the second canal in the molar due to inadequate removal of the dentine. So, always try to locate the distolingual canal in the mandibular premolar, mesiobuccal to in the maxillary molars. Coming to modern access cavity preparation, the need of the combination of tooth needs, the operator needs, and the restorative needs leads to a new term known as modern access cavity. Whatever we discussed till now is a traditional approach, but there's a lot of things that are present in modern access cavity, like the ninja cavity preparation that you must have heard on Facebook, a lot of images on Instagram that are seen of ninja cavity preparation, or you can talk about soffit, the banking cavity preparation, or a calorie appearance. All these can be discussed in another seminar, which is about modern access cavity preparation. Why there is a need of modern access cavity is because you all know that endodontic preparations are more brittle and hence more vulnerable to fracture. Why the teeth are more vulnerable to fracture is because loss of moisture. Predominant reason is that endodontic treated teeth are more prone to fracture is because of the structural loss of the tooth, which requires a restoration. Also, the degree of stress experienced by the tooth is more. Also, the biomechanical preparation leads to the remaining tooth structure responsible for the resisting fracture. So, all these causes lead future need to start doing modern access cavity preparation, which will be discussed in another seminar. Also, I would like to conclude by saying access opening is a starting point of successful treatment and are the key of unlocking healthy smiles. Remember, the basic is very important. Knowing where and why an access openings are made forms the core of the effective dentistry. From there, we explore the different ways to create these openings and adapting techniques to fit each case in unique needs. The journey of mastering or access opening is ongoing, and it's through these forms like these that we can collectively push the boundaries of what is possible in the field of endodontics. I would hoping to have another seminar with modern access preparation. For now, thank you. And if you have any queries, you can connect to me. Thank you.
Thank you so much, Dr. Kanchan, for covering that very important topic of access opening in routine dental procedures. I'm sure a lot of dentists must have gained a lot of clinical tips and tricks from that session. Thank you so much for your valuable time and for making time for this presentation. To all our audience members, thank you so much. We will be back with another session of Dent-E-ssentials next week. Until then, please take care and happy dog. Thank you.